Just confirm it. Okay, just see whether it is there or not. Coming around now? Okay, right. Hello everybody. This is Dr. Tilak from the Department of General Medicine, Medicity. So today I'll be discussing second part of Parkinsonism. Previously I have discussed Parkinson disease. That is also kind of Parkinsonism. But today I'll be discussing second part, that is Parkinsonism plus. It is also called atypical Parkinsonism. So I'll just come to the definition or the meaning of the word Parkinsonism plus. So first let us reiterate few important points about Parkinsonism. What do you mean by the word Parkinsonism? So when a patient has got these motor manifestations in various combination, it is called Parkinsonism. So it may be rest tremors, slowness of movements, bradykinesia, hypertonia in the form of rigidity, and some abnormality of the posture or loss of postural reflexes, and some motor abnormality in the form of motor blocks or freezing. If these are present in various combinations, it is called Parkinsonism. It simply means patient has got some motor abnormality. It does not mean which type of disease is there. This Parkinsonism may be seen in so many conditions. It may be idiopathic, then it is called Parkinson disease. When it is associated with some additional features like cerebellar dysfunction or brainstem dysfunction or cerebral dysfunction, then it is called Parkinsonism plus. I'll come to that. Okay, so this is just to show what are the different manifestations or clinical features of Parkinsonism. It may be slowness of movements, it may be rigidity, which may be lead pipe or cogwheel, it may be tremors at rest, it may be some abnormality of the posture, it may be some other abnormality like a shuffling gait or stooped posture. So these things constitute Parkinsonism. So basically Parkinsonism is some complex manifestation. It's a syndrome characterized by various features which I have already mentioned. So it basically reflects there is some abnormality of the extrapyramidal system, especially the basal ganglia or its connections. So now what is the meaning of Parkinsonism plus? When these Parkinsonism features are associated with some additional features, then it is called Parkinsonism plus. So additional features may be in the form of some dysfunction of the cerebrum. So there may be some cognitive dysfunctions may be there, some language dysfunction may be there, or there may be some additional features in the form of cerebellar problem, like there may be ataxia, incoordination, or sometimes Parkinsonism may be associated with dysfunction of the brainstem. So some pyramidal manifestations may come, or other brainstem dysfunction may come. So whenever Parkinsonism is associated with any of these, it is called Parkinsonism plus or atypical Parkinsonism. So just a brief description of the basal ganglia and its related anatomy and physiology. So what is the meaning of basal ganglia? What are the structures included in basal ganglia? So these are the different structures which are included in the basal ganglia. One is the striatum, which is basically a combination of putamen and caudate nucleus, and then subthalamus nucleus. Thalamus is not included. And then globus pallidus, both internal and external part, and substantia nigra, which is there in the midbrain. So these are basically the structures included in the definition of basal ganglia. So this is just to show that this is the basal, this is the caudate nucleus, then this green one is the putamen, this is globus pallidus, internal and external, subthalamus, and in the midbrain there will be substantia nigra. So same thing you can see in the MRI also. Caudate nucleus is here, putamen is here, and this is globus pallidus, internal, external, and subthalamus will be just below the thalamus, and there will be substantia nigra in the midbrain. Same thing is visible here. Caudate, putamen, globus pallidus, subthalamus, and others. So if you look in the midbrain, this relatively darker structure, hypointense, this is substantia nigra. This is an important part of the basal ganglia. So basal ganglia occupy a lot of space in the brain. So what are the functions these basal ganglia perform? So basically they do not perform any function on their own. whatever the functions of other parts of the brain, they modulate that. Like function of the motor cortex of the cerebrum is motor activity, but how to modulate that, about the speed, about any unnecessary tremors are coming or not, these things are carried out by basal ganglia. So basal ganglia basically regulate the function of other parts of the brain. Like motor activity does not depend on the motor cortex alone. Motor cortex is important, then how that activity is to be carried out at right speed, it is not slower, it is not faster, and unnecessary involuntary movements like tremors are not coming. That is the job of the basal ganglia. Similarly, the emotional function, which depends upon the temporal lobe and the frontal lobe, that also is modulated by the basal ganglia. And also cognitive function. Cognitive function is basically served by the frontal lobe, but again frontal lobe needs input from the or modulation by the basal ganglia. So if a patient has developed some disease of the basal ganglia or its connection, then the patient will develop Parkinsonism. So those features I have already discussed. So just briefly I'll describe those dysfunctions which we see in patients with Parkinsonism. So patient may have bradykinesia. Any part of the body may be affected, whether it is a upper limb, lower limb, or tongue, or anything. So all the motor activity will be slower than normal. Then patient will have hypertonia. So it will affect both the group of muscles, agonist and antagonist, or anti-gravity and other group. Both the group of the muscles will have hypertonia at the same time. And it may be associated with cog-wheel rigidity, which means the rigidity, the hypertonia will be there, and it will be combined with tremors. So the passive movement will be jerky. And then other feature of Parkinsonism is tremors at rest. So these tremors will come only at rest, and during motor activity, like we are moving the hand or leg, these tremors will disappear. And subsequently, the patient while walking will have a stooped posture, will be bending forward most of the time. So this is again a feature of Parkinsonism. And sometimes it may become very pronounced, so patient will keep the back bent forward significantly. But in the laying down posture, this back will be straight. So there are the different postural abnormalities seen in Parkinsonism. So besides the motor manifestations, patients with Parkinsonism may have other manifestations. It may be related to the cerebrum, it may be related to other parts of the central nervous system. So patient may have some cognitive impairment. How early or how late it comes, it depends upon the underlying type of Parkinsonism, whether it is Parkinson disease or whether it is Parkinsonism plus. So depending on that, these features will come early or late. I'll come to that. The patient may have some sleep abnormalities may be there. Sometimes they have some sensory disturbance. Subjective manifestations are seen more often than objective. Then patient may have some neuropsychiatric manifestations, and subsequently autonomic dysfunction may come. Again, at what time autonomic dysfunctions come, it depends upon the type of Parkinsonism. If you are talking about Parkinson disease, these features will come later in the course of the disease. If the patient has got Parkinsonism plus, then autonomic dysfunction, cognitive dysfunction will come early. These are the other features which may be seen, autonomic dysfunction. So this autonomic dysfunction can affect any part of the body. It may affect the cardiovascular system, genitourinary system, sexual dysfunction, etc. may be there, depending on which part of the body is affected more. So coming to Parkinsonism plus, as I mentioned, when Parkinsonism is associated with the dysfunction of the cerebrum or brainstem, then it is Parkinsonism plus. And there are different types of disorders in this category. One is the multi-system atrophy, one is progressive supranuclear palsy, other is cortico-basal degeneration. And again, multi-system atrophy is divided into two parts, MSA-P and MSA-C. P stands for Parkinsonism, C stands for cerebral, which means a patient who has got multi-system atrophy clinical picture, but Parkinsonism features are predominant. And MSA-C means a patient who has got multiple system atrophy clinical picture, but cerebral dysfunction is predominant. So I'll come to that one by one. So coming to multi-system atrophy. So multiple system atrophy simply means there is involvement of multiple parts of the central nervous system. So it will affect the basal ganglia, it will affect the brainstem, it will affect the cerebellum, it will affect the cerebral cortex in various combinations. So basically, it's a degenerative disorder. It is not because of some infection or inflammation or vascular problem. So the usual features of multiple system atrophy or MSA is dysfunction of the autonomic system. So the various manifestations will come. As I mentioned, it may affect the gastrointestinal tract, urinary bladder, sexual functions, or blood pressure, etc. And other features will be Parkinsonism, which I have already discussed. Features of Parkinsonism. And then patient will have some dysfunction of the cerebellum also. So patient will have ataxia. So these manifestations will be present in MSA. So basically, it's a reflection of involvement of multiple sites in the central nervous system. As I mentioned, this MSA is divided into two major types, MSAP and MSAC. As I mentioned, when we say MSAP means the predominant features are Parkinsonism, like bradykinesia or rigidity, etc. But if the patient has got predominantly cerebellar dysfunction, ataxia, muscle incoordination, etc., then it's called MSAC. So if you talk about the prevalence, it is relatively less common as compared to the Parkinson disease. So it is seen about 5 cases per lakh population, and mostly it is seen in middle age or later part of the life. When the patient has got early onset, in the early phase of the MSA, the patient may only have Parkinsonism features like rigidity may be there, bradykinesia may be there, and other features will come later. So in the early stage, it may look like Parkinson disease. So in early stage, it may be difficult to differentiate Parkinson disease from MSA. But after some time, the patient will have features of cerebellar dysfunction or cerebral dysfunction. Then you can make the diagnosis of Parkinsonism plus. So as I mentioned, MSA may have dysfunction of the autonomic nervous system. So it may result in various kinds of clinical manifestations resulting from different organs. So it may affect the urinary bladder. So there will be various types of dysfunction. It may be urgency or retention, etc. in various combination. It may affect the gastrointestinal tract also. It may cause cardiovascular system dysfunction to patient. So patient may have postural hypotension. Patient may have other manifestations of the dysautonomia. Sometimes it may cause RBD, or which is called REM sleep behavior disorder. What happens in this? That during sleep, the patient will have various motor activity. The patient may be speaking, patient may be moving the hands, legs as if he's doing some work or is fighting with somebody. This is called RBD. Or patient may have the autonomic dysfunction affect the skin also. And other manifestations in MSA may be related to sleep. Or patient may have even respiratory dysfunction in the upper part of the respiratory system causing stridor. So these dysfunctions may occur in various severity and combinations. So if we talk about one part of MSA, which is MSA-P, what happens? The P means the Parkinsonism features will be more prominent than other features. So patient will have Parkinsonism features just like Parkinson disease. But the important feature in MSA-P is that in Parkinson disease, it is asymmetric clinical picture. But in MSA-P, there is bilateral symmetrical involvement of the limbs. So bradykinesia or rigidity will be bilateral symmetrical, and tremors will not be present in MSA Parkinsonism. And these patients have rapid progression of the disease. So various types of abnormalities, postural abnormalities, postural instability will come very quickly. In case of Parkinson disease, these things come after many years or maybe even several decades later. But in case of MSA, these problems related to dysautonomia, related to gait abnormalities come early within few years. And most of the patients will be severely affected, so they may not be able to move around within 5 years. So basically the problem is the patient will have various motor abnormalities which may affect any part of the body, upper limb, lower limb or bulbar muscles. So patient may have dysarthria also. Sometimes the patient may have some involuntary movements like myoclonus. And then the patient, as I mentioned, autonomic dysfunction may also come. But the important problem is that sometimes the patient may have only the sleep abnormalities may be there, and motor manifestations may come later after a gap of few years. So in the beginning, the patient will be having only some sleep related abnormalities like RBD. So the diagnosis may not be made at that time, but subsequently as more prominent features of MSA appear, then you can make the diagnosis. Other type of MSA is MSA-C. So C basically stands for cerebellar dysfunction here. So any patient is going to MSA clinical picture, but the cerebellar dysfunction is more prominent, which means cerebral ataxia will be there, muscle incoordination will be there. So then we call it MSA-C. So how do we make the diagnosis of MSA, multiple system atrophy? So look for the clinical features of autonomic dysfunction. So bedside evaluation you can carry out. Look for any postural abnormalities there or not, in the blood pressure, or skin temperature is normal or not, or sweating on both the sides is same or not, and change of heart rate with change in the posture is there or not. So these things you can find out, and also take the history related to dysfunction of the gastrointestinal tract or bladder bowel functions. So that will give some idea about autonomic dysfunction or not. And also you can do some special tests like response of the growth hormone to clonidine challenge. So this thing is there or not. Subsequently, if you can do a specialized test, like you can do a needle electromyography of the rectal sphincter. So because of this involvement of the autonomic system, there will be denervation. Then features of denervation will be there in the electromyography of the rectal sphincter. And then you can carry out brain imaging. MRI is more sensitive compared to CT scan. So in MRI you can see certain features which are suggestive of MSA. If you look at the putamen, by the side of the putamen there will be some hyper intense rim on the outer side, and also there will be decreased signal from the putamen. And if you look at the brain stem, there will be a cross bun sign. I'll just show a picture of that. If you show this brain stem sign, so this hyper intense appearance is there. This is called cross bun sign, which is quite suggestive of MSA. Another feature, this is basically the putamen here, and outside the putamen you can say hyper intense signal. So this is again suggestive of MSA. If you want to carry out further evaluation of MSA, you can do special radioisotope scan or PET scan can be done. That will show abnormalities in the affected parts of the brain. So routinely this test is not required, but if you want you can carry out. Then you will see there will be decreased acetylcholinesterase activity in the subcortical parts of the brain on PET scan imaging. So what is the basic pathology in MSA? Basically, as I mentioned, it's a neurodegenerative disorder. There is a loss of neurons in certain parts of the brain, especially striatum, substance nigra, and other parts. And subsequently, it may affect either cerebellum or the pons also, resulting in various manifestations. So how do we differentiate MSA from Parkinson disease? Because I have mentioned Parkinson disease will have same motor manifestations like rigidity may be there, bradykinesia may be there, etc. And MSA-P will also have similar picture. One is that if there is rapid progression of the disease, like postural instability has come very early within first few years, then it goes more in favor of MSA. Okay, if the patient has got rapid disease progression again, and bulbar dysfunction like dysarthria, dysphagia is coming early, again it suggests MSA. If other autonomic abnormalities are coming very early, again it is suggestive of MSA, not Parkinson disease. So various abnormalities like respiratory dysfunction or stridor, etc. may come very early. And then patient may have some higher mental abnormalities like emotional disturbance may come. So all these things coming early, and if there is motor manifestation which is bilateral symmetrical, it is more suggestive of MSA, not Parkinson disease. So all these features may be there. Then you can think of the possibility that it is not usual Parkinson disease but MSA-P. So how do we treat? Basically, it's a neurodegenerative disorder. There is no specific treatment available, either pharmacological or surgical. So you can try some drugs which are used in the treatment of Parkinson disease. So you can start with the levodopa and see the response. Though response either may be mild or may be short-lived, but there is no other treatment available. But if there are other manifestations like autonomic dysfunction may be there, so you can give the usual treatment for those autonomic dysfunction manifestations. Like if a patient has got orthostatic hypotension, the usual treatment for that may be given to these patients. As I mentioned, this is basically relatively rapidly progressive neurodegenerative disorder. So most of the patients will be bed bound or wheelchair bound within 5 years, and the survival is also not very long. Usually within 7 to 9 years, most of the patients succumb to the disease. Other Parkinsonism plus disorder is progressive supranuclear palsy or PSP. So what is PSP? So if you look at atypical Parkinsonism, this is only next, second, as far as neurodegenerative disorders affecting the motor system in the form of Parkinsonism is concerned. So if you look at Parkinsonism, it may be because of idiopathic reason, what is called Parkinson disease. It may be because of some etiology. It may be vascular problem, some toxins, etc. So if you look at Parkinsonism because of vascular etiology, like multiple strokes are there, then it is slightly more common. Then it is followed by PSP. The prevalence, as I just said, is relatively less. You can say up to 6 per lakh population. And it is seen more often in males as compared to females. So clinical features are basically important features are, one is the involvement of the extraocular movements. So initially the patient will have abnormalities with the vertical movement of the eyeball, upward and downward. Subsequently other movements may be affected. Other feature is the patient will have hypertonia in the form of rigidity. It affects the entire body, but mostly the axial skeleton, the neck and back, etc. And subsequently the patient may have features of pseudobulbar palsy. So patient may have some bulbar dysfunction, some emotional instability, or pseudobulbar palsy type features may be there. And later the patient will develop higher mental dysfunction in the form of dementia. So basically the patients who have got progressive supranuclear palsy, the usual beginning is in the form of some abnormality of the gait. While walking, they may have sudden fall without any anticipation that something is wrong. The person may be just walking and suddenly the patient may fall. And most of the time this disorder starts in the later part of life, after 6th or 7th decade. And patient may have severe rigidity affecting mainly the axial skeleton. So patient may have rigidity affecting the skeleton mostly in the central part, axial part, and subsequently the limbs also. But the important feature is that again it will be bilateral symmetrical. In Parkinson disease, asymmetry is the usual feature, while in atypical Parkinsonism, symmetrical motor features will be there. Other differentiating feature from Parkinson disease is that in Parkinson disease, the patient while walking will have a stooped or bent forward posture. But in case of PSP, most of the time these people will keep the trunk extended and even the limbs extended. So this is the difference in the posture between PSP and Parkinson disease. And if you look at the facial expression of patients with PSP, they will have this type of appearance. The patient will not be able to move the eye up and down. They will have wide-eyed stare, as if they are having some fear or something. And there may be other features on the forehead. There may be furrowing may be there, visible on the forehead. And the other features will be more deepened as compared to normal individuals. So if you look at a patient who has got this feature and the entire body in erect posture is hyper extended, including the neck and the back, then you should think of PSP. So other features of PSP will be some pseudobulbar palsy will be there. So basically it is called emotional incontinence also, like while talking the person may start suddenly either crying or suddenly start laughing. So basically it is not deliberately, it happens on its own. And other features of bulbar palsy may be there, like some speech abnormality may be there. There may be some difficulty in swallowing also. And other features of Parkinsonism like hypokinesia or bradykinesia will be there. And patient may have some ataxia also. As I mentioned, PSP is a basically kind of Parkinsonism plus. So there may be some cerebral higher mental dysfunction may be there. So the patient may have prominent features of frontal lobe dysfunction. So patient may have various abnormalities like executive dysfunction may be there, like what to do, how to do, planning and decision making will be severely affected. And other features of frontal lobe abnormalities may be there, like concrete thought process, difficulty shifting states, etc. And subsequently, the frontal lobe dysfunction may result in decreased interaction with the people around. So patient may have severe apathetic state. And as the disease progresses, there will be more dysfunction of the higher mental functions. So patient may be having severe dementia. The basic important feature of PSP is that ophthalmological abnormalities. So patient will have abnormal movement of the eyeball, especially vertically. So if you can just ask the patient to look up and down, that will show some abnormality. If that is not clear, you can take the help of optokinetic nystagmus. So horizontal saccades are not affected as much. So if you ask the patient to look up and down, or you can take the help of optokinetic nystagmus, then you can detect the abnormality of eye movement vertically. But this eye movement abnormality will not be seen in all the patients, or may not be seen early. It may develop only later, and there are some uncommon patients where the eye movement abnormality may not appear at all. So other features of PSP is that patient will have broad-based gait and knee extension. It is unlike Parkinson disease. In Parkinson disease, the patient will have more flexed posture or stooped posture. But in case of PSP, it's a broad-based gait with knee extension. And instead of turning en bloc as happens in Parkinson disease, the patient with PSP, they turn with the toes. They will extend the foot and they will keep the toe straight, and then they will turn to the other side, and sometimes it may result in fall also. And other features of Parkinsonism or PSP may be freezing. What happens when the person is walking? It will be no problem, and while walking suddenly the feet will stop moving. So what happens, the upper part of the body is still mobile in momentum, but the lower part, the feet may stop moving. So suddenly there will be freezing of the feet, but the other upper part of the body may still be mobile, so patient may fall forward. Just like MSA, PSP is also a rapidly progressive neurodegenerative disorder. So within few years, within 2 to 4 years, most of the patients will have significant manifestations related to either rigidity or ocular movement or some higher mental dysfunctions. So many patients within 4 years will have need for some help while walking or while turning in the bed. And subsequently the patient may have various bulbar manifestations like dysarthria or dysphagia may come, and visual manifestations may also come. So these things appear within few years, within 2 to 4 years. But in case of Parkinson disease, these things will appear after several decades. So PSP and MSA will have severe manifestations and rapid progression of the disease within few years. So if you look at the imaging of the patient with PSP, the important feature is the atrophy of the midbrain. And if you look at the other parts of there may be some signal abnormalities. Increased signal in the MRI may be there, affecting the midbrain, globus pallidus, and red nucleus also. And as a result, there will be dilatation of the ventricles, especially the third ventricle. And subsequently, because of involvement of the cerebrum, there will be atrophy of the other parts of the brain also, including frontal lobe and temporal lobe. And if you take the sagittal cut, you may see a special appearance of the midbrain, what is called hummingbird sign. So it is like this. You can see this part looks very narrow, like the beak, and lower part is not atrophied. So this midbrain atrophy is there. It gives the appearance of hummingbird appearance. And because of atrophy of the basal ganglia, this third ventricle will be dilated. Okay. And also, if you take the axial cut, this part of the midbrain will be more prominent, like the eye of the Mickey Mouse. So what is the basic pathology? Basically, it is basically a neurodegenerative disorder, mainly affects the midbrain and its connections. So there will be atrophy of the midbrain, and sylvian aqueduct will be dilated because the brain matter in the midbrain is smaller than normal. And if you look at the pathology, the substance nigra will be having loss of pigment. And subsequently, you will find atrophy of the other parts of the brain like frontal lobe or temporal lobe or substance nigra. So basically, it's a relatively less common as compared to Parkinson disease, and it occurs sporadically. It is not because of genetic disorder, but there are some cases where the familial cases do occur, but this is very uncommon. Okay. So even if the familial cases are there, all the individuals in the same family will not have same clinical picture. So one individual in the family may have one type of manifestations, second individual may have slightly different type of manifestations. So this type of heterogeneity will be there even if the family members are having the disease. But there is no specific etiology for that. No toxin, no infection, or no other environment factor has been associated with the development of progressive supranuclear palsy. So how do we treat? Again, it's basically neurodegenerative disorder that there's no definite treatment available, but for bradykinesia and rigidity we can take the help of the drugs which are used in the treatment of Parkinson's disease like levodopa. But the improvement, if at all it occurs, it is mild improvement only, and it's a short-lived improvement, and subsequently there is no response to the treatment. So there is no specific treatment for the treatment of this PSP, but if there are other manifestations like dysautonomia is there, you can give the treatment the way we give treatment to patients with autonomic dysfunction because of other etiology. If there are other manifestations like cognitive dysfunction has come, then you can take the help of drugs like donazepam. That will help. If the patient has got some pseudo-bulbar effect like emotional incontinence is there, then you can take the help of drugs like amitriptyline. Those patients who have got severe rigidity, if it is localized, like there is a retrocolic neck posture or blepharospasm is there, then you can inject the botulinum toxin locally, but it cannot be given all over the body. So prognosis, as I mentioned, is a neurodegenerative disorder which is having a rapidly progressive course, and within few years most of the patient will have severe neurological deficit and will require substantial help from outside, and most of the patients succumb to the illness within about 8 years. Other Parkinsonism plus disorder is the cortico-basal degeneration or CBD. So basically here there is involvement of the cerebral cortex and also the basal ganglia. So the clinical manifestations are more wider as compared to Parkinson's disease. So basically there may be a combination of cortical dysfunction and combination of extrapyramidal system. So the patient may have clinical picture which may be just like PSP. There may be rigidity, there may be bradykinesia, there may be autonomic dysfunction, there may be coherent mental dysfunction or cognitive dysfunction. But the important feature is that here the manifestations are unilateral most of the time, unlike PSP. PSP is bilateral symmetrical, while CBD is mostly unilateral or predominantly unilateral. So if you can compare the incidence with the other types of Parkinsonism plus, it is relatively less common, even less common than PSP. And again, most of the time people who are affected are basically in the 6th and 7th decade of life. And patient may have predominantly a motor disease, like there may be some apraxia, alien hand or rigidity, etc. may be there. But this clinical picture is highly variable from individual to individuals. So various manifestations of CBD may be in the form of the patient may have Parkinsonism, like rigidity may be there, or sometimes they may have some involuntary movements, or some dystonia may be there, myoclonus may be there, and they may have various types of cortical manifestations. Apraxia may be there, alien limb syndrome may be there, some cortical sensory loss may be there, language dysfunction may be there. So these cortical manifestations will be there along with motor manifestations, and this combination will be highly variable from individual to individuals. So it may look like a picture of PSP only, but PSP is more of a bilateral symmetrical disorder, while CBD is mostly unilateral. So if you do the evaluation, you will find there will be atrophy of the cerebral cortex, which is asymmetrical. That is the reason why the clinical manifestations are more prominent on one side, and because of atrophy of the cerebral cortex, there will be widening of the fissures, and sulci will be having dilatation. And if you do a special investigation like PET, you will find decreased metabolism in the cerebral cortex because of atrophy. Again, if you do other like SPECT, again you will find asymmetrical blood flow. Basically, it signifies there is significant involvement of the cerebral cortex, which is asymmetrical. One side is more than other. So basically, it's a tau positive neuronal type of neurodegenerative disorders that results in loss of various neurons in the cerebral cortex and also in the basal ganglia, especially in substantia nigra. So basically the manifestations will be highly variable. They may be just like manifestation of PSP or Parkinson disease or frontotemporal dementia may be there, or Alzheimer's disease. So patient may have cortical dysfunction, motor dysfunction, etc. in various combinations. So treatment is basically just like other Parkinsonism plus. There is no specific treatment. Being a neurodegenerative disorder, treatment may be started with levodopa, but most of the time there is no response. And if the patient has got other manifestations, you can give symptomatic treatment. Like if a patient has got myoclonus, then you can give drugs like benzodiazepine. If the severe dystonia is there or severe rigidity is there in a particular part of the body, then you can take the help of drugs like botulinum toxin. Otherwise, there is no specific treatment and prognosis is very poor, and within few years most of the patients succumb to the disease. With this, I come to the end of this discussion. I hope it must have benefited, and with this I have covered both Parkinson disease and today I have discussed Parkinsonism plus. So you should know the meaning of Parkinsonism plus. Parkinsonism, as I mentioned, basically bradykinesia, rigidity and other motor manifestations. If only these things are there, then it is called Parkinsonism. But if the patient has got motor manifestations of Parkinsonism and it is associated with other dysfunctions of other parts of the brain, like if there is associated cerebellar dysfunction or cortical dysfunction, cerebral dysfunction or brainstem dysfunction, then it is called Parkinsonism plus or atypical Parkinsonism. So thanks for watching, and now I close the session with this.